Dear Dr. Ta Ba Thang, and all my esteemed colleagues. When it comes to the topic of asthma, we might feel there is nothing particularly new. But honestly, when a pregnant woman comes to an asthma clinic, we cannot avoid two specific feelings. First is the feeling of being slightly hesitant in receiving the patient. Second is that, if we are experienced, we will slow down to reflect. When such pregnant women visit an asthma clinic, what do we need to do differently compared to a typical asthma patient? What I often do in my clinical practice is to recall a little bit about the changes considered characteristic of a person with bronchial asthma during pregnancy. Second, I mentally weigh the benefits and risks of the medication I am prescribing to the patient. And third, if the patient unfortunately has an acute exacerbation, we must guide them on medication use as well as all methods to support future control, especially after the exacerbation. When we talk about pregnant women with asthma, they are actually a quite special group, a special population. Why are they special? It is because only a small proportion, about 3 to 8%, of pregnant women have asthma. Therefore, in clinical practice, we sometimes find it difficult to have the opportunity to repeat these specific treatment issues. Second, pregnant patients with asthma experience pathophysiological changes in many aspects. And third, about 10% of pregnant women, when they have an exacerbation, need systemic corticosteroids, especially oral ones. And finally, we must always remember to balance the benefits and risks based on each specific treatment step for an asthma patient. We can look at this in the most fundamental way. Respiratory physiological changes in pregnant women generally focus on three main issues. First is the change in several pulmonary ventilation parameters. These changes contribute to altering the metabolic pathways of gases in the patient's blood. And third is the activity of the diaphragm. Why must we pay attention to these matters? Because asthma is one of the three conditions that act as a risk factor for severe ARDS cases in pregnant women. So, let's look back at the first characteristic regarding pulmonary ventilation indicators. If we observe the changes in the patient's chest, between a non-pregnant and a pregnant person, most notably from 7 to 9 months, or the third trimester, we will see that the indices related to functional residual capacity, which is the sum of two components, ERV and RV, will tend to decrease in this third trimester. Is this change significant? Research shows that these indices and their downward fluctuation trend can be quite meaningful. Decreasing by 17 to 20%, which is equivalent to about 500 milliliters for functional residual capacity. For residual volume, we see it can drop by up to 300 milliliters. And finally, expiratory reserve volume also decreases by about 5 to 15%, up to a maximum of 300 milliliters. So, how does this affect the respiratory function of a patient with bronchial asthma, and specifically, what factors must we keep in mind for our clinical decision-making? We can look back at the drop in the axis shown here in pink, which corresponds to the functional residual capacity. Thus, if a person experiences a simultaneous decrease in these two indices, they will have a tendency toward hypoxemia. Because we know that functional residual capacity is the patient's oxygen reserve. Therefore, if during pregnancy, especially in the third trimester, this reserve decreases, patients with asthma during this stage are more prone to oxygen desaturation when their asthma is uncontrolled, let alone if they experience an acute exacerbation. The second factor is the increase in residual volume. We know that residual volume is the pulmonary reserve remaining when the patient exhales maximally. And these patients tend to retain air due to a reduced ability to exhale, leading to air trapping, which causes significant disturbances in arterial blood gases that we will discuss later. In summary, changes in pregnancy regarding pulmonary ventilation assessment indices significantly affect asthma, especially in patients at risk of acute attacks, as they drop oxygen levels faster due to lower functional residual capacity and have difficulty compensating during exacerbations. A second point is that if not well controlled, alveolar collapse can occur more easily, increasing the severity of ventilation-perfusion mismatch. Thus, besides hypoxemia, a major consequence affecting not only the mother directly but also the child indirectly is the PaCO2 index. In a pregnant woman, the PaCO2 level tends to be on the lower side throughout pregnancy. This low trend ranges between 28 and 32 millimeters of mercury due to increased ventilation activity stimulated by progesterone. However, if this pregnant woman has asthma, even without an acute attack, we observe that the PaCO2 remains within the normal range upon examination. But in reality, this normal level is at the lower threshold. And in essence, this CO2 retention warns of a potential risk of respiratory failure. The consequence for the mother with potential hypercapnia is that it can reduce the fetus's ability to eliminate CO2, thereby causing a silent disorder known as fetal metabolic acidosis. And the consequences, as we know, affect the child throughout the third trimester. This is very important. Besides the direct mechanical effects and the manifestations in ventilation indicators as well as ventilation perfusion parameters, we must also evaluate the endocrine effects during pregnancy. These effects primarily act directly on bronchial constriction as well as bronchial dilation. With progesterone playing the role of a mild bronchodilator, it helps improve symptoms in asthmatic patients who have high progesterone levels. However, these pregnant women will have a ratio of estrogen and prostaglandins that increases the bronchial constriction reflex. But these pregnant women do not have a synchronization between the rates of increase or decrease of these hormones. Therefore, this is a factor that is difficult to predict. According to the author Schatz in 1999, they proposed a 1/3 rule, meaning 1/3 of pregnant women may improve. That is, their improved manifestations can be inferred indirectly through the role of progesterone when it peaks, or 1/3 become worse due to the effects of hormones that have bronchoconstrictive properties, and 1/3 are considered to have absolutely no changes in terms of symptom assessment or the frequency of emergency attacks. Thus, the response to the varying degrees of hormonal changes in pregnant women is a very important reason why it is difficult to predict the progression of asthma in a pregnant woman. So, in clinical practice, when we understand these issues, what is the most important thing for us to do? Clinical decision-making is the most fundamental aspect we need to keep in mind. This is a summary that is quite connective between the physiological changes in pregnant women, their influence on asthma pathophysiology, and the clinical impact, providing us with a more focused perspective on patient management. Hyperventilation due to increased tidal volume means that when a patient's asthma is uncontrolled or they enter an acute exacerbation, a decrease in VT will have a greater impact, leading to respiratory failure. So, what do we need to do? We need to monitor VT closely, especially during acute exacerbations, to prevent the progression of respiratory failure. The two indicators we have analyzed so far relate to the decrease in functional residual capacity and ERV, which reduces reserve capacity and causes the decline in blood oxygen levels in pregnant women to progress faster during an acute attack. Therefore, it is essential that when a person has an acute asthma attack, we must monitor SpO2 closely, even if we do not initially perceive that the patient's oxygen levels are dropping. The third effect relates to increased progesterone and estrogen causing bronchodilation or altering bronchospastic reflexes, which we need to confirm, especially regarding hormonal fluctuations that can worsen or cause loss of asthma control, particularly when levels peak in the third trimester. We need to evaluate asthma control periodically, because there are cycles that can influence the severity of bronchial asthma. Similarly, regarding increased oxygen consumption and reduced O2 reserves due to the decrease in FRC, we see a risk of hypoxia for the mother and increased CO2 due to reduced fetal clearance, so we must minimize the duration of maternal hypoxia to protect the baby. And one point that we can see quite clearly is that there is a phenomenon of preserved respiratory muscle strength even if the diaphragm is elevated, so the patient's breathing can still be effective if asthma is well controlled. Therefore, in clinical assessment, the lungs' ventilation capacity will still be ensured if we control asthma well, even though the patient's diaphragm may have undergone changes during pregnancy. And finally, there is an increased awareness of dyspnea. Pregnant women, especially in the third trimester, can easily confuse physiological shortness of breath with an asthma attack. As a result, we get confused by the information and fail to form an assessment, leading to a late diagnosis. Therefore, we need objective assessments using simple and feasible tools for pregnant women, such as PEF or SpO2, to distinguish between physiological dyspnea and an actual acute asthma attack. In general, we need to recognize some important principles in managing asthma in pregnant women, aiming to reduce the frequency or duration of maternal hypoxemia and ensure a continuous oxygen supply for the fetus. Thus, to achieve this, we still need to combine various different measures. Although it follows the same sequence as any other asthma patient, we need to delve deeper into the specific characteristics. Accurately classifying the level of control will help in prognosis and personalizing treatment for the patient, especially regarding the trimesters, the first, second, and third trimesters, with the changing characteristics of the symptoms. Monitor the peak flow index periodically to detect early the moment the patient starts to lose control. Third, in any situation, stopping medication is not recommended because it ensures safety for the mother and avoids the risk of acute attacks as well as excessive medication use for acute management. And finally, education on avoiding allergens to minimize the need for medication as much as possible, reducing unwanted effects on the fetus. So, after we have the goals and the steps to keep in mind when receiving a pregnant woman showing signs of losing control or an acute asthma attack, we also need to recall a little about the safety profiles of asthma medications. Which is higher, the benefits or the risks, and we will make adjustments accordingly. Of course, we know that with the wide variety of current treatments, first-line therapies such as inhaled corticosteroids, especially budesonide, or short-acting beta-2 agonists like salbutamol, and long-acting ones like salmeterol and formoterol, are all considered relatively safe during pregnancy and breastfeeding. Angina 2024 recommends that we absolutely must not stop ICS during pregnancy because the benefits of asthma control far outweigh the theoretical risks of unwanted side effects from the medication. Regarding risk assessment related to medication use in the fetus, we have experimental studies, and these studies are selectively evaluated for some commonly used drugs, such as budesonide and formoterol, and these drugs have a potential risk of causing malformations, though at a low rate. And it is recommended that this level does not necessarily apply to humans, so if ICS and LABA were used stably before pregnancy, we must continue them, not stop them, and prioritize monotherapy with budesonide if possible, especially in the first trimester. Consider reducing the dose or adjusting the frequency during the high-risk period for congenital malformations, specifically 30 to 60 days after conception, in cases of mild, stable asthma, and it is necessary to individualize and select patients based on the risk-benefit stratification for each person. After we identify the impacts of pregnancy on a pregnant woman, we review all the factors related to the benefits and risks in treating patients with these medications. The first step in controlling an acute asthma attack is to strictly follow the 3-level stratification for control. First, the patient needs to handle the situation immediately on the spot, at home. All patients should be provided with an asthma action plan, and the presentation by Master Thiên Quân earlier gave us an overview of the diverse tools for asthma management, including the action plan. Hopefully, in the future, Mr. Quân will include action plans with a footnote highlighting specific points for pregnant women, especially in the 3rd trimester. The action plan will include when to use regular asthma medications and how to step up therapy and initiate OCS when necessary, and how we can access medical care if symptoms do not respond to home management. So, we will instruct the patient on how to change their medication usage in the asthma action plan in the simplest way using 2 components. First, increase the frequency of reliever medications. Second, increase the controller medication dosage. So, for a pregnant woman, what do we need to keep in mind? That is, if we use one of the 2 regimens we heard about in the previous 2 presentations, if we use an ICS formoterol preparation, we increase the reliever dose for the patient using SMART therapy. However, if we use high, repeated doses, we need to consider limitations, especially in the 1st trimester. And the maximum dose of formoterol is 72 micrograms. If we choose ICS LABA, we step up to a higher dose formulation or consider adding separate ICS inhalers to avoid excessive LABA dosing. The second level is visiting a medical facility. If outpatient management has failed, we need to re-evaluate whether it is truly an acute asthma attack or physiological dyspnea in a pregnant woman. We assess the severity of asthma based on the worst feature among 3 categories: moderate, severe, and very severe. Whichever feature is the worst, we will classify the patient into that level of severity. We re-evaluate whether the patient understands and is correctly following the action plan content we previously discussed with them, and whether the patient is performing anything incorrectly compared to our instructions, especially regarding inhaler techniques. Several factors can contribute to triggering an acute asthma attack in patients, such as comorbidities, especially infections, or the patient self-medicating with drugs that cause unwanted reactions. In general, the management of rescue medications for acute asthma in pregnant women remains the same as for all acute asthma patients, with an average SABA dose of 4 to 10 puffs, repeated every 20 minutes in the first hour. And in cases of severe or critical asthma, the use of this SABA is only temporary, allowing us to transport the patient to a medical facility with sufficient experience to treat such severe and critical cases. Regarding systemic corticosteroids, we use an average dose of prednisolone at 1 mg per kilogram per day, and the dose can be increased for severe cases. Regarding the principles of treating acute asthma in the hospital, in general, for severe attacks, we treat with medication first and emergency procedures second. However, for critical attacks, we reverse this to ensure the patient's survival rate. For the use of bronchodilators during an acute asthma exacerbation, we also consider some options alongside the base SABA dose of 4 to 10 puffs repeated 3 times. We can use additional short-acting anticholinergic drugs to increase treatment efficacy. Besides that, we can use fast-acting LABA medications such as formoterol combined with budesonide preparations, which are safe for pregnant women. Other changes to the asthma action plan, such as the use of symptom-relieving medications or increasing controller medication doses, must follow recommendations and guidelines from the Ministry of Health. And we can begin with a broader range of OCS doses for acute exacerbations, from 0.5 to 2 mg per kilogram. And we use it short-term for less than 10 days. Because a short course of 5 to 7 days is almost equivalent in therapeutic efficacy to a 2-week treatment. And if we treat for over 2 weeks, we need to follow the principle of corticosteroid tapering and closely monitor the dose reduction. The follow-up after an acute exacerbation is a very important aspect to protect the patient, especially as they progress further into the trimester. In the 3rd trimester, patients will have more manifestations and issues, especially related to respiratory limitations, so we need to choose safe treatments for the patient, as well as start a roadmap for monitoring and preventing subsequent exacerbations. Re-evaluating the inhalation technique as well as compliance, and the factors causing poor medication adherence, also need to be assessed objectively. We can select appropriate devices for the patient, check the inhalation technique and correct errors when the patient makes mistakes in inhaling the medication, and ensure that you have a checklist for each inhaler to help the patient gradually get used to therapy with an inhalation device. Address modifiable risk factors for exacerbation recurrence to limit the sole reliance on only increasing controller or rescue medications. We instruct patients on self-management or using treatment methods that help them reduce flare-ups, avoid contact with all possible allergens, and provide training programs that include self-management skills. And one of the very important tools in this is using electronic software to send data to specialized centers so we can further evaluate cases where our initial management is not entirely suitable for a simple asthma patient during a progressing pregnancy. Through my presentation, I would like to convey 3 messages. The first message is that asthma in a pregnant woman has a specific pathophysiology. This specific pathophysiology increases ventilation but reduces residual lung capacity, leading to increased oxygen consumption and susceptibility to hypoxemia. This makes pregnant women more prone to progressing to acute respiratory failure faster than non-pregnant individuals. Secondly, the safety of medication use, especially ICS and SABA, has strong safety data during pregnancy. Delaying or self-discontinuing medication due to concerns for the fetus is a factor that promotes obstetric complications. Third is the principle of managing exacerbations. Actually, it is not much different from the methods we use for the general population, the general asthma patient population. Prioritize the use of SABA and systemic corticosteroids early, maintaining SpO2 at is greater than or equal to 95%. And do not stop asthma medication even during labor. Closely monitoring medication techniques, control levels, and evaluating treatment after an exacerbation will help ensure safer outcomes for pregnant women with underlying asthma and their fetuses. My presentation ends here. Thank you sincerely for your attention. Yeah.